Okay, we are almost ready. 7 o'clock right now, and waiting for the cowbell. Dear colleagues, I'm Filippo Crea, Editor-in-Chief of the European Journal. Welcome to this new dialogue, to our Socratic dialogue with top experts in the world. Please ask questions. The last time we received a large number of interesting questions. Was a very interactive dialogue. And this is what we want to have today, a very interactive dialogue. And this is really an important dialogue with a fascinating person, a fascinating guest today. I'm sure you know him very well. And the guest is Bernard Gersh. And I will host him with Cecilia Linde, who is one of the executive editors of the European Art Journal. And the title of this dialogue is interesting: A Journey from Zambia to Rochester, USA, via South Africa. Well, this is in one sentence the life of Bernard Gersh. And I'm really eager to ask Cecilia to start our dialogue with Bernard. Cecilia, please.
Thank you very much, Filippo. Well, Professor Bernard Gersh is a professor of medicine at Mayo Clinic, and he was trained in the University of Cape Town in South Africa, where he is Doctor of Philosophy, also a degree from Oxford University as a Rhodes Scholar. Professor Gersh has impressively 1,300 publications and was twice named Thomson Reuters list of individuals with the greatest numbers of citations, and named highly cited by Web of Science. He is an honorary professor of medicine at the University of Cape Town, South Africa, an adjunct professor at Duke University School of Medicine. He was appointed honorary clinical professor at the Center for Clinical Pharmacology, William Harvey Research Institute in London. Dr. Gersh has received many prestigious awards, and as examples are the ACC Distinguished Service Award, the Hatter Award for Advancements in Cardiovascular Science for University College London and University of Cape Town, Mayo Clinic Distinguished Alumni Award, Distinguished Scientist Award of the American Heart, and designated Master of the American College of Cardiology. In 2005, Professor Gersh was appointed Doctor Honoris Causa at the University of Coimbra, Portugal. For the ESC, he was designated as 4 Legends of Modern Cardiology, one of 4 Legends of Modern Cardiology in 2013, and has received both the silver and the gold medal. Professor Gersh, it is a great honor and privilege to interview you. Before I come to the first question, I would just like to have a little citation. Livingstone first saw Victoria Falls from a tiny Livingstone Island, which sits on the Zambesi River on the lip of the falls. He wrote in 1857, "Creeping with awe to the verge, I peered down into a large rent, which had been made from bank to bank of the broad Zambesi, the most wonderful sight I'd witnessed in Africa." So with this little teaser, I would like you to talk about your fascinating journey.
Thank you, Cecilia. Just one comment about being one of the 4 legends of modern cardiology. John Cam, who you all know and is a great friend, his comment was, being called a living legend is at least better than the alternative. And well, Victoria Falls is one of the most incredible sights. It is today. I always have a problem peering down because it is just massive, and you can get vertigo when you do it. But we did spend quite a lot of time there. Part of my family actually lived in Livingstone itself. Although we were in a different part of what was then Northern Rhodesia. So really, I grew up in Zambia. I was born in South Africa because my mother went down to South Africa for the birth. But I grew up in Northern Rhodesia, which then became Zambia. My family were real pioneers in that part of the world. My father went up in the 1920s. And I was educated there until the age of 10 or 11. And then, like many other of my contemporaries, if you wanted a decent education, you had to go somewhere else. We were a mining town right on the border of the Belgian Congo, really. Great place to grow up. But at the age of 10 or 11, we had this discussion with our parents, and it wasn't, would you like to go to boarding school? It was, look, it's your choice. You can go to South Africa or England, you choose. And my younger sister, who's 3 years younger than me, she had a third choice. She was able to go to school in Southern Rhodesia, which became subsequently Zimbabwe. And so I was educated. All my schooling was in South Africa from the age of 10 or 11. And I then went to the University of Cape Town, where I was graduated and did my internship there. And then I got a scholarship to Oxford, where I did a PhD, or as Oxford calls it, a DPhil. And then I went back to South Africa for my residency and cardiology training. And I was on staff at Groote Schuur Hospital in Cape Town for several years. And then I think at the age of about 36, 37, I had the chance to go to the Mayo, and I left South Africa and went to the Mayo Clinic, where I spent nearly all of my career.
So we have a small greetings here from Dr. Delane Kitzman, a former trainee of yours who spent 2 months in Zambia with you or in your medical school. And he or she asked, what were the most vivid memories of your time in Zambia?
Yeah, hello, Delane. And I think probably my best memories were, my dad had a wonderful ranch about 200-300 miles from south of where we lived. And he was a terrible driver, but he also became a pilot. I think his pilot's license was, he was the third person in Zambia to fly a plane, his own plane. And the only way he got there was one line of rail that ultimately was going to go from the Cape to Cairo, but it never quite made it. But the way he navigated was he would fly down on the railway line, and when he thought he got to where he needed to be, he would just go low and look at the name on the train station, and then turn left, and he would come to the ranch. So probably my most vivid memories were wonderful times on that ranch. I used to ride horses. There was a ton of wildlife, and that, I think, and it was, the freedom of being able to ride a horse through the bush and look at wildlife. It was incredible. And to this day, photographing and looking at wildlife is still one of my passions.
Well, thank you, Bernard, for giving us this beautiful picture and for explaining why you've been such a brave person moving around. It's from your father, obviously. Well, so
didn't have any choice.
So when you did start at Mayo Clinic, what was your initial research interest, and did you have a mentor?
I did indeed. The chief, I was the first person that Dr. Robert Fry recruited when he became chairman of the Division of Cardiology. And one of the aspects of Mayo that really attracted me was, first of all, he was a great chief and has become a great friend, and he's still working full-time at the age of 90. But one of the reasons I went to the Mayo Clinic was when I was first looking at a job, they told me about the Olmsted County database, which is this incredible, very granular database that was used primarily for epidemiological reasons. And I remember saying to him, well, would I have access to this? Because I think I could use this database to try and answer clinical questions. So some of the very early work I did was with the Olmsted County database on, I think our first paper was on, quote, low atrial fibrillation, which we published in the New England Journal. And it was a very simple study. It was about 120 patients that we could follow. We had a 15-year follow-up on them, at 100% follow-up. And then the other aspect of my early research at Mayo was, or early work at Mayo was, Bob Fry was one of the principal investigators of the CAS trial. And the CAS trial was one of those 3 early trials of bypass surgery versus medical therapy. And the CAS trial also had a registry of about 20,000 patients that were not enrolled in the trial, but they were in a registry. And it was an incredible resource. So I did quite a lot of, we wrote quite a lot on the results of bypass surgery in, quote, the elderly, which at that time was over 65. And he was my mentor for that. And another mentor was Lloyd Fisher, who was a biostatistician at the University of Washington in Seattle. And that's where the core lab was for the CAS trial. And he taught me a huge amount about biostatistics and what you've got to know and what you don't have to know. And I remember he saw me wandering around with Bradford Hill's textbook of biostatistics, and I'm trying to understand how to do multivariate analyses. And he gave me some great advice. He said, you'll never be able to understand that. You don't have the mathematical knowledge to understand the equations, but I will teach you how to use a multivariate analysis. And that's actually something that stood me in really good stead, because I really earned my living to some extent doing multivariate analyses for years, but I still don't understand the equation, and I'll never understand it. And the same thing now applies to the work we're doing with artificial intelligence. I can't understand what's under the hood of the black box, but I think I know how to use the data and use the output.
Well, that's a wonderful place to have started in, and with all these the historic studies like the CAS trial, I think we're all us who are slightly younger than you are, this is one of the fundamental studies on the effects of bypass surgery that we all refer to. And then there's fantastic registries that the Mayo Clinic do have. You have a very diversified research interest, as I understand it, ranging from arrhythmias to cardiomyopathies. Do you have any favorite, or does it vary over the years and decades?
Well, from a clinical standpoint, I think that the two aspects, I think, clinically that I found just life-changing was the advent of reperfusion therapy. I mean, my very first job in Cape Town as a very young consultant was to run the coronary care unit. And at that time, we were doing acute coronary bypass surgery for myocardial infarctions. And then along came streptokinase and the GC trial. When I came to Mayo, and my going to Mayo was the best thing I ever did. I just loved working there, and I loved the people I worked with. But when I got to Mayo, this was really the start of the reperfusion era, and 1980. And Ray Gibbons, who is a colleague and a nuclear cardiologist, was doing a lot of work on measurement of infarct size with sestimony. And really, we published so much. What was so exciting about it was there were so many questions about reperfusion therapy. What's the role of collaterals? What's the duration of time before reperfusion and so on? All these questions, and we were able to answer them, together with others outside Mayo. So I found that incredibly exciting. I remember the first primary PCI. A woman, kid of class 3, anterior infarction, 2 a.m, and about an hour and a half later, she wanted breakfast. I thought, I've never seen anything like this. It was incredible. And then the other was in electrophysiology. We had a large series of WP surgery for WPW. And our surgeon, the late Gordon Danielson, was busy writing it up. I think it was 400 cases. and I saw the first radiofrequency. We did our first radiofrequency ablation. And, to see that delta wave just go away. And I saw him in the corridor and I said, by the way, surgery for WPW is now of historical interest only. So that was both a clinical interest, of course, and a research interest, but things change. I mean, reperfusion for STEMI is now a matter of logistics. I mean, we know all about it. The only other frontier of reperfusion, and I see Gerd Horsch there, is a reperfusion injury. And I don't believe that this is a dead issue. I still think there's a role for modifying reperfusion injury in patients that are quite sick to start with. The Condi Eric trial from Sweden and UK was an excellent trial that didn't show a benefit of modifying reperfusion injury with preconditioning. And the reason it didn't was because the mortality was so low. It was a victim of its own success. So we're now looking with Holger Thiele in Germany and Gerd Horsch, we're actually have a pilot study now of reperfusion injury in patients that are killer class 2 or more. So otherwise, I think reperfusion, we know what to do. It's just a matter of logistics.
Well, that's wonderful. And it's wonderful that you continue to keep this interest. I know that you didn't want to talk too much about the past. It rather focus on what's happening right now. And I know you have passions right now for artificial intelligence, amongst other things. So,
well, thank you, Cecilia. Paul Friedman is chairman of the department in Rochester of Mayo, has had a long-standing interest in artificial intelligence and the electrocardiogram. And I'm fortunate to be invited to be part of that group. And so we really doing a lot of work actually with machine learning and the actual digital electrocardiogram. And it's quite amazing. I mean, I can tell you what the ejection fraction is with a high degree of accuracy, area under the curve 0.9. And also, it looks like that we can predict who in sinus rhythm will go into atrial fibrillation. So that's an area of great interest. And what Paul and some of my colleagues are doing, Peter Noseworthy and Costas Siontas, is actually integrating this into our clinical practice. So if I'm doing an electronic consult from home or telemedicine, I can literally pull up the ECG and then the AI ECG dashboard, and it'll tell me what the likelihood is of a low ejection fraction. What's the likelihood that this patient will get atrial fibrillation? It'll tell me whether the patient is male or female, which, I mean, I don't know that that's exactly clinically valuable, but one of my colleagues did say the other day that he was a bit disappointed to find that he had, when he looked at his own ECG, there was an 80% chance that he was female. But that's been really interesting. We're doing a lot of work on post-operative atrial fibrillation, which is not just a transient nuisance. It's a cause for concern, and it's a marker of future events. And that's very much of a current interest. I think the other one is I've, like everybody else, have got involved in COVID and the late cardiovascular complications of COVID. We're involved in a number of studies, and I'm very interested because of my background in cardiovascular disease in the developing world, and particularly Africa, and what will be the role of artificial intelligence, because I think there's going to be a huge role for it in many parts of Africa where you don't have a cath lab on every corner or an echo machine in every hospital. So those are continuing interests. I think maybe starting with a CAS study, I've always maintained an interest in coronary revascularization, whether it be the indications versus medical therapy, whether it be PCI versus bypass, and the continuing controversy. So that continues.
So that sounds interesting. I'm terribly interested in how you can use AI in your clinical practice. That's the first for me. I haven't heard that before. So But
It's it is a learning experience, Cecilia.
Yes.
I mean, we're just feeling our way.
Yeah. So we have a question from Dr. Amrushain Shabekar. Do you suggest that middle career researchers should go abroad to improve their careers?
I think it depends where you come from to a large extent. I think going abroad is always a part of the learning experience, just living in another country in a different culture. But I think it's not so much going abroad, it's where you go to. So it's what institution do you go to? What are your interests? What are their interests? And do they match? And I think that for many people in, I don't want to use the developing world, but maybe the low and middle income countries, they just don't have the research infrastructure that the large countries do. And of course, it pays to go to major research centers for your research experience. And I went to Oxford. I worked in a dog lab looking at the effects of anesthetics on cardiac function. I never went back to the dog lab, and I didn't plan on doing that for a career. But what I learned was terrific. And I learned research methodology, scientific rigor, statistics. And I think
that sounds fantastic. I think that is the reply to Dr. Shabekar. And finally, before leaving over to Filippo, were there any difficult moments in your brilliant scientific career, or did everything go just like smoothly?
No, it did not, as you know. It never does. I think the two most difficult, when I went to Oxford, I came out of a very clinical medical school in South Africa with a terrific, I mean, the kind of pathology we saw was amazing and challenging. But then I had to adjust to a research environment for 2.5 years, and a very rigorous research environment. So I had to learn a lot of lessons there. And then I think the other very difficult part of my career, for me personally, after 15 years at Mayo, which I loved, I went to Georgetown as chief of cardiology in Washington, D.C. It was a great city to live in. But compared to Mayo and the tremendous amount of funding and support, Georgetown was a medical school that had a number of problems and issues. So it was a difficult move for me. And then it was equally difficult to make the decision after 6 or 7 years that I'm going to go back to Mayo. And so that was a difficult time.
I understand. So maybe, so you would recommend staying, if you find a great place like Mayo, stay there. That's what I hear.
Well, yeah, I don't know. I mean, it's all part of the kind of, ups and downs of life. On the other hand, living in Washington was terrific.
I can imagine.
In DC, one of my twin daughters worked in the White House for Hillary Clinton. Oh. And then Chelsea Clinton came and did a high school elective with me. And I was actually at Oxford with Bill Clinton, although I never met him while I was there. I met him subsequently, but just Washington was a very exciting place to be. It just wasn't a great job. And then I went back to Mayo in 1999, and that was the best move I made.
Fascinating. So Filippo, would you like to continue?
Cecilia, thank you for your questions to Bernard. Bernard, I have always admired your encyclopedic knowledge of cardiovascular medicine and cardiovascular literature. And in addition, you are a very wise man. So you are the right person to ask a very, very specific question in line with the debate generated by the ischemia trial, which perhaps you can summarize for our audience. Well, the question, very simple, is should we revascularize a stable oligosymptomatic patient with a proximal LAD stenosis?
Very difficult question, and in a way, the ischemia trial doesn't answer that. Now, the ischemia trial is a really good trial, 5,000 patients, looking at revascularization, mainly with PCI versus medical therapy in patients with chronic coronary syndromes or chronic stable angina. And it was a neutral trial. But we have to wait and see what happens at 5 to 10 years, because the curves are starting to diverge in favor of the invasive approach. I think really the main lesson from the ischemia trial, and what was surprising, is that the extent and severity of ischemia did not determine the adverse events. Now that's really a surprise. And so where I think that the guidelines could be modified is this. I think that ischemia alone on a stress test is probably not an indication for revascularization or even angiography. I think you need ischemia plus other high-risk features, such as a drop in blood pressure, short, very poor exercise tolerance, LV dilatation on a nuclear study. So it's not just ischemia alone. I think it's ischemia with other high-risk features. So if I saw a patient, if the patient was sent to me already with an angiogram showing a proximal LAD stenosis, I mean, my threshold for intervening is very low, because maybe it's the oculostenotic reflex. But what I would do in someone like that, I would obviously measure, I'd like to see what the FFR is, and I'd like to see what their performance is on the treadmill. And if they were able to, if they had a normal functional aerobic capacity, and obviously if the FFR is greater than a 0.8 or whatever, then I would not intervene. I think optimal medical therapy has made amazing strides since the early trials in the early 1980s of revascularization versus medical therapy. So I think you have to use clinical judgment. I do think that one great lesson from the ischemia trial is we need to rethink how we risk stratify. And I think I'm involved with a review that's going to hopefully come out in Nature Reviews in 2-3 months. And the whole review is on plaque characterization. Can we identify vulnerable plaques? What should we? There's a great deal of interest in this. And this comes back to your great area of interest, Filippo, microvascular function. And so I think the time has come to really rethink how we risk stratify people. And a stable angina is not stable. It's stable until it becomes unstable. And some people never become unstable, and some people do. So we go back to the vulnerable plaque and new ways of characterizing it.
Okay, well, if I well understood, a lot of emphasis on non-invasive and clinical characterization of the patient is needed before jumping to coronary angiography and stenting or revascularization. We need a good characterization of patients before rushing to coronary angiography.
Yeah, I think both on patients, but then I think also that when we go to angiography, whether it be CT or invasive angiography, I think there's some really interesting work going on in terms of characterizing the vessel and the plaques. Fascinating. And I think using a variety of different techniques, perhaps we are on the cusp of identifying those plaques that are truly vulnerable and need to be addressed.
Well,
so it's the patient and the plaque.
I see in the audience Peter Libby, who is executive editor of the European Heart Journal. And Amelia, yes, please, let's unmute Peter. Well, coming to the vulnerable plaque, we have a top expert here with Peter. Peter, what are your comments on the vulnerable plaque? What can we do about it? Does it exist?
Yeah, so, I'm on public record as saying that the effort to try to scope out a particular vulnerable plaque and intervene upon it may be a fool's errand, because it is the burden of disease, and it is maybe other plaques than the one that you're going to intervene on that will cause the next event. So we're very interested in involving technologies for identifying vulnerable plaques, such as the fat attenuation index, but all of these techniques need to be rigorously validated. And then the hard part is doing a clinical trial to show that you can change therapy based on some imaging modality and improve patient outcomes. And that's a sticky wicket because even to get equipoise on the part of clinicians and patients to not have a biased enrollment in a randomized trial, I think is a challenge.
Thank you, Peter.
I think there's been a proof of concept trial, that's all, carried out by Greg Stone, but it's a tough trial to try and, I don't think we're ready for that trial yet, but we may be in a year or two. Okay,
so in summary, in the stable patients, let's focus on a clinical approach before rushing coronary angiography, and let's optimize medical treatment. I think these are two important messages. And then the quest for the holy grail of the vulnerable plaque continues, but with several problems, as highlighted by Peter. Well, again, in the field of ischemic heart disease, we are learning that 50% of patients with suspected angina and evidence of myocardial ischemia do not have obstructive atherosclerosis. And symptoms in ischemia are related to microvascular dysfunction. Did we miss this signal for a long time? Bernard, what are your feelings about?
Well, I go back to your paper on the recurrent angina after revascularization. I think it was a fantastic paper. I never realized until I read it that 30% of people in the Courage trial who were revascularized, I think, were symptomatic at 1 year, and it wasn't due to restenosis. And so you got me interested in the field of microvascular dysfunction, and I became like a reformed alcoholic. You know, I never thought about it, and then suddenly I became a great enthusiast. And you and I wrote a review with Paolo Comici and Juan Carlos Caschi for Circulation, and I think it's incredibly important. I think not only in terms of who should be revascularized and who should not be, but it may be a very important tool in distinguishing who could benefit from PCI versus bypass surgery. There's some very interesting work on coronary flow reserve from the group at the Brigham, actually, on coronary flow reserve and the results of bypass surgery versus PCI. And I think, we have not paid it the attention that it deserves, and people like you and others have really, I think, made major contributions in that way, in that regard.
Bernard, one last question in the field of ischemic heart disease. A lot of interest in inflammation, but from a therapeutic standpoint, CANTOS and the colchicine trials have shown benefit of anti-inflammatory treatment, but also some problems, some issues related to safety. What are your feelings about inflammation? It's an interesting target, but what is the future?
You know, I'm not a shy person, but to ask me to talk about inflammation with Peter Libby sitting there is pretty difficult. I actually was on the data safety monitoring board of the CANTOS trial, which Paul Ridker did, and Peter was involved with. Very good trial, positive result. Interestingly, there was a benefit on cancer in that trial. I don't know where that's going to go, but the side effects of the drug were really understood right from the beginning. I mean, this monoclonal antibody to interleukin-1 will predispose to infection. It's a form of immunotherapy, if you want to call it that. And so the fact that there was a higher rate of infection, really, we expected that. So it was a positive trial. And I think it was also, at the same time, a major proof of concept. Now, with colchicine, there are some questions there. There is an unexplained rate of non-cardiovascular death in the colchicine-treated group. I think we need more information. I don't know why.
Thank you.
But maybe Peter would comment.
Peter, again, a short comment on this hot topic you know so well.
Yeah, well, thank you, Bernard, for being on the Data Safety Monitoring Committee. And I remember we had a face-to-face meeting with you at one point, maybe a third of the way through the trial. Yes. And you were asking some pointed questions in the non-executive closed part of the meeting. So I thank you and Sir Rory Collins for persevering despite there being a signal for infection. I think what we learned from CANTOS is what kind of infections they are, and they're not weird and wonderful exotic infections. They were not opportunistic. They were everyday viral and bacterial infections. We know who's susceptible. So I think that some of the risk of giving an anti-inflammatory therapy can be mitigated with what we've learned. And we're certainly hoping to apply that in the trials with anti-IL-6 that are currently underway. So we're just, I quote Churchill when I give a talk on this, where at a certain turning point in one of the last great wars, he said, this is not the end, but it may be the beginning of the end. So I think that we need to persevere, learn carefully what we've gleaned from the clinical trials, and move forward to find an anti-inflammatory intervention which maximizes benefit and minimizes harm.
No, I think that, sorry.
Please, Bernard.
Oh, with all trials that take several years, it's really interesting and something that has to be dealt with in the guidelines, and that is that if you think of the trials of coronary revascularization, they antedated many of the tools that we use today, like OCT, IBUS. They antedate many of the new drugs, the SGLT2 inhibitors, for example, anti-inflammatory agents, PSK9 inhibitors. So what makes it difficult in all of these trials is the fact that mortality rates are low and improving. And so you have to, when you do a trial, you need to really look at the incremental benefit of an agent over and above what you already have. And so when you're doing a trial that takes 6, 7, 8 years, to some extent, you have to accept that that trial is a little obsolete by the time it's completed. There's nothing we can do about that. We just have to accept it. And it becomes more and more difficult to show a difference as the mortality rate really goes down, down, down.
Thank you, Bernard. I see in the audience also Gerd Heusch. Amelia, can you please unmute Gerd? Gerd is editor-in-chief of research in basic cardiology, in addition to be a top scientist. Well, what is your favorite therapeutic target in inflammation, Gerd?
You put me into the same difficult position as you put Bernard before. Hi, Bernard. With Peter Libby around, I don't even care to say.
You don't dare.
For me, a top target is still tumor necrosis factor alpha. That is very much upstream in the signal transduction cascade of inflammatory processes in the arterial wall, but also in the myocardium. So my expectation would be that with hitting a TNF-alpha, you could possibly target the inflamed coronary circulation and also the myocardium. And I realize that previous studies have not gone so well with TNF-alpha, but they were mostly targeted at heart failure and not so much to the possibly inflamed microcirculation with the inflammation of the myocardial areas just surrounding that microcirculation. So my target would be TNF-alpha.
Okay. Well, let's close this mini congress in ischemic heart disease, and I'm sure Cecilia's got other questions for Bernard.
Yes, here we move to a group which does have a high mortality rate, and that's the group of hypertrophic cardiomyopathy. So recently you written a paper about how to assess the risk for sudden cardiac death. And traditionally in Europe, with using our guidelines, and the American ones, is based on echo parameters, history of sudden cardiac death, to some degree, presence of ventricular arrhythmia. But you said that perhaps you showed that the sensitivity for actually predicting sudden cardiac death was relatively low. And as I understand it, you're suggesting new imaging tools to add to get, amongst others, myofibrillar disarray, which I find fascinating. So could you give some recommendation about to assess sudden cardiac death risk in hypertrophic cardiomyopathy, please?
Hypertrophic cardiomyopathy is really just a fascinating disease to study. Yeah, I mean, the positive predictive value of any of our algorithms is only about 15%. So whether you're using ESC or ACC, the fact is that the majority of patients who have a defibrillator will never get a discharge. So there are a lot of cost implications of that. And I think there's a lot of argument about the ESC guidelines versus the ACC, AHA guidelines. And I think it's just a matter of semantics. It's simply, if you use the ACC guidelines, you will put in more defibrillators that will not discharge, but you have a greater sensitivity. And with the ESC guidelines, there's more specificity. What I really think, and here I must acknowledge Paolo Camici and Antonio Policia, and we do have an editorial or a commentary somewhere in the publication process right now, and that is a call for action that we really are not very good at predicting sudden death in people with hypertrophic cardiomyopathy, at least for primary prevention. And I think, and I'm really, when I say I think, they think, and I agree with them, that one of the factors that we've got to really start looking at is a subendocardial ischemia, microvascular dysfunction, and its role. And I think it is important. The techniques are now there for studying them. Preliminary studies are really interesting. And I do think that this call to action is valid. I think we're not going to just get there with an echo or looking at an ejection fraction or something like that, or a Holter. We need a completely new approach. So right now we have the guidelines and we have to use them. They're good, but we need a completely new approach, I think.
We also have the sarcoma versus non-sarcoma disease. We have the registries. Do you think they will be in any way helpful?
I think they will. I think the SHARE registry is a huge registry, and it's already showing differences between people with sarcomeric genetic HOCM and those who, quote, don't. And we're also looking at that with artificial intelligence at the moment, the ability to detect HOCM. And our problem is the model that we have, which was published in JACC, the model is really based upon our own population at the Mayo Clinic, which is primarily Caucasian. And what we really need to do is look at our model and see how it applies to athletes and other ethnic groups.
Yeah,
so we're collaborating with people around. Yeah, we're collaborating with a bunch of people around the world.
Yeah, because the mid-cavity obstruction, which is, or apical, seems more common in Japan settings. So maybe that is something. Yeah. So that's fascinating. So let's shift to something where we're really at the end of the beginning, as I see it, and that is stem cells. Professor Brownwell has identified that as the treatment of the future. I believe he means for refractory angina and severe heart failure. This is a truly tricky subject. You have written several papers in a positive tone. Could you explain to us which cells, which way of delivery? Is it the cells? Is it some indirect factors? What is your take on this?
My take on it is not as a basic scientist at all. It's as a clinician. But we've got some good basic scientists who have been working on this at Mayo, and I've had the chance to work with them. I think that this is really, to quote Peter Libby and Winston Churchill, I think this is, are we at the end of the beginning or at the beginning of the end? And I gave a talk once in front of a bunch of stem cell biologists, and I got got it mixed up. I said we're at the beginning of the end. And I meant to say we're at the end of the beginning. I think we've been naive to really believe that in 15 years, this would be solved. There was too much hype. Some of that is our fault, physicians, the media, the public. And then when you have all that hype, and then the trials are neutral, there's a reaction. And there's a very strong reaction that from some groups suggesting that this has been overfunded and the money has been could be diverted more productively elsewhere. Professor Baumrold wrote a great article at the time of the paradigm trial of Entresto, sacubitril valsartan. And he pointed out that it took 50 years from identification of the angiotensin converting enzyme to this trial. 50 years. And we think we can solve the issues of stem cell biology and turn it into a clinical tool in 10 to 15 years. We were naive. The field has also been hurt, I think, by some trials that are poorly designed. Unfortunately, there have been much publicized cases of fraud that have hurt the field, scientific misconduct. And then I think the other thing that is difficult with stem cells is you really can't do a 20,000 patient trial. So you're always working with underpowered trials. I mean, the largest trial is, I think, 800 patients at the moment. I think we've got to, the last review we wrote, we really made a point that it's time to step back and start rethinking how to go about this. And I do think that probably the lowest hanging fruit are the trials of stem cells for refractory angina. There have been 3 trials, they all, I think the signal was positive in all of them. And that I think will come about. And there are a couple of trials ongoing right now that really may show that where it's for paracrine reasons or angiogenic or whatever, that stem cells may benefit people with refractory angina who are non-revascular, who are not candidates for revascularization. In terms of regenerating myocardium, that's another huge step, and I can't predict. I think that the biological patches are interesting. A lot of work going on in Germany. But somehow you have to get those patches to integrate with the rest of the myocardium. You know, it's not just growing more muscle, that it's got to be electrically integrated and so on. And then I do think that the first trial of embryonic stem cells is taking place right now under Dr. Joseph Wu in Stanford. And I mean, the concept remains exciting. It is logical, but it's going to take a long time.
Well, thank you.
I'd hate to see it prematurely terminated.
Yeah, I think the expectations on the part of the patients were too high, and we were perhaps to blame for raising these expectations too. Whereas I see that the need in heart failure would be much greater than in refractory angina. But maybe now, on the other hand, when we have all these new heart failure drugs, things will be a little bit different. But I don't think anybody can tell. It's truly a very tricky area. And I think we'll leave it at that and turn into simpler things like atrial fibrillation. So there's a lot of hype on device-detected atrial fibrillation, such as watches or phones. How do you think that will be applied in everyday care?
I think this may be the most controversial area in clinical electrophysiology at the moment. What do we do with device-detected atrial fibrillation? And right now, I think there's a general consensus that if you have device-detected atrial fibrillation that lasts for more than 24 hours, or maybe more than 12 hours, that's like clinical atrial fibrillation. So do you anticoagulate them? Yes, depending on the CHA2DS2-VAS scores and so on. What do you do if it's 6 minutes to 6 hours or 6 minutes to 12 hours. And I think we simply do not know. We really do not know. And the recent Danish loop study has provided us with some information. But right now, for asymptomatic device-detected atrial fibrillation, what I am trying to do, if it's less than 12 hours of atrial fibrillation, is enter the patient into some of the randomized trials. I think that we will hopefully, we will get the answers in 2 to 3 years in terms of, in general, should we anticoagulate? But whether we will get the answers, whether the trials are large enough to answer the question about what about 1 hour of atrial fibrillation over 3 months versus 10 hours, we may not get those answers. We may need to look at other biomarkers and various other things. But it's a very interesting area. The watch gives everybody headaches because if your patients have watches, you're going to get a lot of correspondence, I tell you, in the patient portal. So I think we've got to wait and see. It's really interesting. The other area that I think is fascinating is from the ASSERT trial in Canada. Jeff Healy has shown that if you have device-detected atrial fibrillation that progresses in duration over a certain period of time, and then the episodes become longer and longer, there's a really significant increase in heart failure. And that's fascinating. Yeah,
that's really fascinating. And then we have, I hope that your TCA trial is going to be, that's concluded its inclusion, and that I hope that will report fairly soon, perhaps in a year or so, and then NOAA trial to follow. What I find in the clinics is exactly what you're saying. All the patients come with their phones, smart watches, ask me to comment on this and that actually generates quite a lot of work. I'm not sure what benefit it does, to be frank. So maybe the artificial intelligence may help something there. We need additional tools because right now I think it creates both anxiety, fixation with health, and unnecessary work. That's my take on this.
We're certainly developing, we're actually working on models right now. We've just got funding to try and see if we can predict which patients will go into heart failure with atrial fibrillation, clinical and subclinical.
That's really interesting. I don't know about how we are about time, but I have one very important question, I think, for the young listening out there, and that is that you are an outstanding and worldwide renowned speaker. What do you recommend to our college for developing these skills in rhetoric and to become an excellent speaker?
Well, Cecilia, thank you for the comment. I think I do give a talk to our fellows as part of their curriculum entitled How Not to Give a Talk, or How to Give a Really Bad Talk. And I think there are 5 points to make. The first is know your subject. I don't talk in areas that I don't work in. I mean, in other words, I keep my talks to the areas that I've worked on or done research in or have clinical experience, but I don't talk outside my field. I don't go and I never give a talk in inflammation or lipid lowering therapy. It's not where I made a contribution. So know your subject and then know your message. What are you actually trying to tell them when you give a talk? And then know your audience. The talk that you give at grand rounds at an academic institution will be very different from if you're talking to medical students or primary care providers. So know your subject, know your message, know your audience, and then most of all, know how much time you have. That's the biggest mistake that we all make. And my friend, late friend and mentor, Lionel Opie, who always wrote beautifully, but he also was an excellent speaker. And he made the comment that if you don't, failure to prepare is prepare to fail. And so I don't think it matters how many talks you've given. You have to be, preparation is the absolute key. And when I prepare a talk, those are the 4 things I try and, construct my lecture around, and that is know your message, know your audience, know the time, and prepare. And there will always be mistakes on slides. There will always be a mistake. You get up there, you think, there's a spelling error, or the slide is clumsy. It takes you too long to describe it. And so what I then do, when I sit down, I make a note of that slide and I redo it. When I get home, I get it redone. Sort of ongoing quality assurance, so to speak.
Well, this is fantastic advice. Listen and learn, everybody, including myself. So now I lead over to you, Filippo.
Well, along this line, I have an interesting question from a colleague, Dr. Gudarzi Nejad. I hope the pronunciation is fine. It's a very sharp question. What is the single most important factor for your success, Bernard? If you come to one word, what is the most important?
I mean, hard work. You're not going to do it between 9 and 5. It's hard work, and you're not going to get your publications and all of the work done during the normal working day when you're seeing patients. So it's hard work, and then from that standpoint, one really needs supportive family, because you're taking time out of their lives to sit in the study. So it won't be done without hard work. And something Dr. Brownwald has always said, you have to have the fire and the passion. You've got to love it. You've got to love it. Otherwise, why do it? And I think his term, the passion, the fire, and you see it. You can see it in young people. Some say they just have what it takes, and they will succeed.
Thank you, Bernard. I'm reading a comment from Peter. Hard work is necessary, but not sufficient. Peter, what do you mean? Can you unmute, Peter?
Yeah, I think, Bernard, you're being modest, because it also takes a creative spark and knowing what problems to study. And you quoted Gene Braunwald about secrets of success and passion. So what he says is you have to enjoy the thrill of the chase. Yeah. And having been on safari with you, I know that you enjoy the thrill of the chase.
That's a great way of putting it. We did some work recently in paroxysmal atrial fibrillation, post-op atrial fibrillation, and we discussed a number of hypotheses, and then to actually see that the data are proving what you had talked about is so exciting.
Well, to be successful, you need many talents. One is not enough, probably. But now let's come to the European Journal, Bernard. You've been deputy editor of the journal in the previous editorial board, and now you are co-editor of North America in the current editorial board. Well, can you tell us briefly about your experience with the European Journal?
It was terrific. I think we did it for 12 years. Tom Lucia approached me at one of the AHA meetings, said they wanted a deputy editor from the States. And it was a great 12 years. It was really a terrific experience. Not only did I learn a lot, I think we were very successful, but it was the interactions with the other deputy editors, and also the people like Amelia and Susanne at the hot house, and in the front office. It was just really pleasant. We had a lot of fun. We had a lot of laughs. We got to know each other, made friends, and we were successful. The journal went from strength to strength. And I have to say, Tom Lucia was a terrific editor, absolutely superb. So it was nothing but a very positive experience. And I now think that the journal is in just excellent hands, Filippo, and is going to go from strength to strength. So I've got nothing but good memories of it. And it really was a great experience. And I just made a lot of friends, and we had a lot of fun. And we took the impact factor from God knows where all the way up. So it was a very positive experience. And I have nothing but great expectations that the journal will continue to be incredibly successful.
Thank you, Bernard. you're still part of the game. I mean, you are co-editor of the journal.
I'm very pleased to be part of the game.
We enjoy your support. It's fantastic, and as shown today during our debate. And I have one final question, again, about the European Heart Journal. What are your suggestions for future dialogues? This has been a new initiative of the journal, successful so far. Any suggestion how we can improve it?
I don't, it's not broken. There's nothing that needs to be fixed. I mean, I've enjoyed listening to the dialogues, and I have to say I've enjoyed being part of it today. I just say, continue to do what you're doing. And as part of the mission of the journal is to go beyond Europe to many other countries. And there are a lot of interesting people in other parts of the world that could contribute to the dialogue in a very positive way. So I think just continue doing what you're doing.
Thank you, Bernard. We are at the end of this fascinating dialogue, as anticipated by Cecilia. It's been 1 hour. We've been debating together, a fascinating hour. Thank you, Cecilia, for hosting our important guest, Bernard. Thank you, Bernard, for your contribution to the journal and to the dialogue. And I remind you that our next dialogue will be, as usual, on the last Thursday of the month, will be, in this case, March 31st at 17 CET. Thank you, Cecilia and Bernard, for this wonderful hour. Bye-bye.
Thank you. Thank you, Cecilia.
Thanks, Bernard. Thank you.
Thank you, everyone, for joining. Just a reminder that our dialogues take place every last Thursday of the month. Many thanks. We're just going to wait until everybody signs off. And everybody has signed off, so it's just us.
Thank you, everybody.
Bye, Bernard.